There was a woman I once cared for. Let's call her Margaret. At 68 years old, her mind was razor sharp. Every morning began with a crossword puzzle. She never forgot birthdays, anniversaries, or family events. Her daughter used to laugh and say Margaret was like the household version of Google because every answer lived somewhere inside her head. Then something changed. Roughly 18 months after a new prescription became part of her daily routine, her daughter reached out to me completely overwhelmed. Margaret suddenly struggled to remember what she had eaten earlier that same day. Roads she had driven for 2 decades now felt unfamiliar to her. During conversations, she repeated identical questions again and again, as if the earlier answers had vanished within minutes. The family feared the worst. A neurologist began discussing the possibility of early Alzheimer's disease. Panic spread through the household, but the truth hiding underneath the surface was something nobody had warned them about. Margaret was not losing her memory because of Alzheimer's. The real culprit was sitting quietly inside her medicine cabinet. After we carefully reviewed every medication she was taking and coordinated changes alongside her physician, something remarkable happened. Over the next 4 months, pieces of Margaret slowly returned. The crossword puzzles came back. Her clarity improved. Her personality resurfaced. This was not some impossible miracle. This was preventable. And that is exactly why this conversation matters. Today, we are going through 9 of the most common medications capable of silently damaging memory and cognitive function. We'll move from drugs people rarely suspect all the way to the hidden combination almost no one warned seniors about. Before we continue, understand this clearly. I am not telling anyone to stop taking prescribed medication without medical supervision. Never make sudden changes on your own. The purpose here is awareness. You deserve to know how these substances may affect your brain, your memory, and your long-term mental health. Being informed is not dangerous. Remaining unaware can be. Now let's begin with medication number 9, diphenhydramine. Think about this for a moment. How many people over 60 keep a bottle of Benadryl near the bed? Probably millions. It is inexpensive, available without a prescription, and marketed as an easy sleep solution. Most people assume it is harmless, but inside an aging brain, the story looks very different. Diphenhydramine belongs to a category known as anticholinergic drugs. Remember that term because it will appear repeatedly throughout this discussion. These medications suppress acetylcholine, a neurotransmitter heavily involved in memory formation, concentration, and alertness. Younger brains can often compensate because acetylcholine reserves are naturally higher. After 60, however, those reserves decline. When a senior takes diphenhydramine night after night, the brain loses even more of the chemical it desperately needs to function properly. Research published in the Journal of the American Geriatric Society revealed that older adults regularly using diphenhydramine experienced a significantly increased likelihood of cognitive decline. Brain imaging even demonstrated shrinkage within regions tied directly to memory processing. The most dangerous part is how hidden this drug has become. It does not only appear in allergy medicine. Products labeled PM, nighttime, or sleep aid frequently contain diphenhydramine without consumers realizing the cognitive consequences attached to long-term use. There are safer approaches. For allergies, many physicians recommend second-generation antihistamines such as loratadine, sold as Claritin, or cetirizine, commonly known as Zyrtec. These medications interact differently with the brain and are far less likely to penetrate the blood-brain barrier in the same destructive way. As for sleep support, we will discuss safer options later. Now let's move to medication number 8. Proton pump inhibitors, often called PPIs. If you have ever dealt with chronic acid reflux, chances are a doctor prescribed one of these medications and instructed you to take it every morning. Many people remain on them not for weeks, but for years without anyone reassessing whether they are still necessary. That is where the danger begins. PPIs reduce stomach acid production. On the surface, that sounds beneficial. But stomach acid also performs a critical task many people never hear about. It helps release and absorb vitamin B12 from food, and vitamin B12 is essential for neurological function. Low levels have been strongly associated with memory loss, nerve damage, depression, and patterns of mental decline so similar to Alzheimer's that even experienced clinicians sometimes mistake one for the other. A study published in 2016 within JAMA Neurology evaluated more than 73,000 adults aged 75 and older. Researchers discovered that long-term PPI users carried a 44% greater risk of developing dementia compared to individuals not using the medication. But the concern may extend beyond vitamin deficiency alone. Additional evidence suggests these drugs could contribute to increased accumulation of amyloid beta plaques, the toxic protein deposits strongly associated with Alzheimer's disease pathology. In other words, we may not only be looking at nutrient depletion, we may also be observing a direct pathway toward neurodegeneration itself. So what can patients do? For some individuals, physicians may recommend slowly tapering PPIs while transitioning temporarily to H2 blockers such as famotidine, commonly sold as Pepcid. Lifestyle changes can also make an enormous difference. Smaller meals, avoiding food late at night, elevating the head during sleep, reducing trigger foods. These simple adjustments often decrease reflux naturally. And for anyone who genuinely requires long-term PPI therapy, monitoring vitamin B12 and magnesium levels on a regular basis becomes extremely important. Now we arrive at medication number 7, bladder control drugs. This category frustrates me deeply because patients are rarely given the full picture. Overactive bladder is not a minor inconvenience. It disrupts sleep, damages confidence, creates embarrassment, and severely affects quality of life. When someone receives a prescription promising relief, naturally they trust it. One of the most commonly prescribed medications is oxybutynin. What many patients never hear is that oxybutynin ranks among the strongest anticholinergic drugs routinely used in modern medicine. It does not remain isolated to the bladder. The medication crosses directly into the brain and interferes with acetylcholine systems essential for learning and memory retention. Long-term exposure has been associated with measurable shrinkage of the hippocampus, the region responsible for organizing and storing memories. This is not temporary brain fog. These are physical structural changes occurring within brain tissue itself. A major study published in the British Medical Journal during 2019 found that seniors using powerful anticholinergic medications like oxybutynin for longer than 1 year faced a 49% higher likelihood of receiving a dementia diagnosis. Nearly half. What makes this especially tragic is how easy the early symptoms are to dismiss. Forgotten appointments, losing track of words, misplacing familiar objects, repeating stories. Families often assume it is simply aging. Meanwhile, the medication quietly continues damaging cognitive function in the background. Fortunately, newer options now exist. Medications such as mirabegron, marketed as Myrbetriq, work through an entirely different mechanism called beta-3 adrenergic agonism. Because of that, they appear to carry dramatically lower cognitive risk compared to older anticholinergic bladder drugs. And for many seniors, that difference may matter far more than they realize. If you are currently taking oxybutynin and you have started noticing changes in focus, memory, or mental sharpness, this is a discussion you need to bring directly to your urologist or primary physician. Do not ignore it. What feels small at first can become something far more serious over time. Now we move to medication number 6. Benzodiazepines. I want to slow down for a moment here because this category carries enormous emotional weight for many people, and for good reason. Medications in the benzodiazepine family have helped countless individuals survive periods of crushing anxiety, relentless panic attacks, and severe insomnia. For some patients, these pills felt like the only thing keeping them afloat during the darkest chapters of their lives. That experience is real, but the science behind long-term use deserves equal attention. These medications function by strengthening the activity of GABA, the brain's primary calming neurotransmitter. In the short term, the effect can feel almost immediate. Fear softens. Tension eases. Sleep finally arrives. The danger emerges when the brain remains under that chemical influence month after month, year after year. A study published in 2022 followed more than 8,000 seniors over a 6-year timeframe. Researchers found that individuals who used benzodiazepines longer than 3 months showed a 51% greater likelihood of developing Alzheimer's disease. The highest danger appeared in long-acting drugs such as diazepam, because these compounds gradually build up inside fatty tissue, including the brain itself. Here is what happens biologically. When GABA activity remains artificially amplified for extended periods, the brain begins reducing its own natural responsiveness. Neuroplasticity starts weakening. The ability to create new neural pathways, absorb information, and adapt to changing circumstances slowly deteriorates. Memory formation becomes sluggish. Emotional balance begins unraveling. A brain once temporarily soothed gradually loses its flexibility and resilience. And then comes the trap. Trying to stop these medications can trigger terrifying rebound symptoms. Anxiety returns harder than before. Insomnia becomes unbearable. Many patients interpret this as proof they still need the drug, while in reality, the medication itself may be fueling the cycle. This point is critical. Never discontinue benzodiazepines suddenly. Abrupt withdrawal can create severe medical complications. Any reduction must happen carefully under physician supervision, often through a gradual taper lasting weeks or even months. There are alternatives worth discussing with a doctor. Buspirone may help with anxiety in some cases. Cognitive behavioral therapy for insomnia, commonly called CBTI, has shown strong results for chronic sleep issues. Certain patients may also benefit from low-dose melatonin or magnesium glycinate. Now we arrive at medication number 5. Statins. Before explaining this category, nuance matters. Statins have saved an extraordinary number of lives. Heart disease continues to stand as the leading cause of death among adults over 60, and for many individuals, these medications remain medically appropriate and potentially life-saving. But there is another side of the conversation many patients never hear. The human brain consists of nearly 60% fat. Cholesterol inside the brain is not simply a dangerous substance waiting to cause harm. It plays a vital structural role in neurological function. Cholesterol helps build the myelin sheath, the protective insulation surrounding nerve fibers that allows electrical signals to travel rapidly and efficiently. It also contributes to synapse formation, the microscopic communication points connecting neurons together. Without sufficient cholesterol availability, brain cells struggle to communicate effectively. When systemic cholesterol levels are aggressively lowered through statin therapy, there is concern that some individuals may cross a threshold where the brain no longer has enough support to maintain optimal structure and signaling. In 2012, the FDA updated statin labeling to include warnings involving confusion and memory problems after reviewing thousands of adverse event reports submitted by patients. That acknowledgement alone caught the attention of many neurologists. Then, in 2023, an analysis published in Frontiers in Aging Neuroscience examined adults older than 70 using high-dose statins continuously for more than 3 years. The study identified a measurable rise in mild cognitive impairment compared to non-users. However, not every statin behaves the same way. Lipophilic statins such as simvastatin and atorvastatin cross into the brain far more easily through the blood-brain barrier. Hydrophilic statins, including pravastatin and rosuvastatin, appear to produce substantially lower cognitive effects in comparative research. So if someone taking a statin develops persistent brain fog or memory difficulties, there may be options. Patients can ask their physicians whether switching to a hydrophilic statin could preserve cardiovascular protection while reducing cognitive impact. CoQ10 levels should also be evaluated because statins are known to reduce this compound, which plays a major role in cellular energy production within the brain. Now let's discuss medication number 4, amitriptyline. This medication shocks people because it is often prescribed for conditions that seem completely unrelated to depression or psychiatry. Doctors commonly use it for nerve pain, migraine prevention, fibromyalgia, and insomnia. Over time, this older tricyclic antidepressant became repurposed for a wide variety of symptoms. In many cases, physicians intentionally choose it because of its sedating effect, especially for patients struggling to sleep. But aging brains pay a price. Amitriptyline ranks among the most powerfully anticholinergic medications still widely prescribed today. Its attraction to muscarinic receptors, where acetylcholine normally functions, is extraordinarily strong. In fact, its anticholinergic effect surpasses many medications specifically designed for bladder disorders or allergies. A major study published in JAMA Internal Medicine during 2015 followed more than 3,400 adults aged 65 and older across a 10-year period. Researchers discovered that prolonged exposure to anticholinergic medications, with amitriptyline among the leading contributors, was associated with a 54% increase in dementia risk. What startled researchers most was not simply the dosage. Even relatively modest amounts taken steadily over years created a substantial cumulative burden on the brain, and the damage rarely announces itself dramatically. Instead, cognition erodes quietly. Words become harder to retrieve. Sequencing tasks feel confusing. Complex thoughts become difficult to organize and maintain. Families assume it is normal aging while the medication continues working silently in the background. Safer alternatives may exist depending on the condition being treated. For nerve pain, some physicians consider duloxetine, sold as Cymbalta, or gabapentin, because these typically create far lower anticholinergic burden. For insomnia, very low-dose doxepin may offer a more favorable receptor profile than amitriptyline. And for mood disorders, many modern SSRI medications are generally viewed as safer for older adults. Now we come to medication number 3, antipsychotics. Listen carefully, because what happens with these drugs inside nursing homes, hospitals, and memory care facilities occurs every single day, often without families fully understanding what is taking place. Antipsychotic medications were originally developed for severe psychiatric illnesses, such as schizophrenia and bipolar disorder with psychosis. These are powerful drugs capable of dramatically altering brain chemistry, and they carry significant side effects. But over time, their use expanded far beyond those original purposes. Today, elderly patients who are confused, restless, agitated, or difficult to manage are frequently prescribed antipsychotics off-label. Not necessarily because they are psychotic, but because their behavior becomes challenging in understaffed care environments. That reality makes many families uncomfortable to hear, yet it is happening constantly. Right now, there are seniors living inside long-term care facilities who are being chemically sedated not primarily for their own medical benefit, but because overwhelmed caregiving systems struggle to handle difficult behaviors. More than a decade ago, the FDA issued a black box warning regarding this exact practice. The agency cited increased mortality risk in elderly dementia patients receiving antipsychotics for behavior-related symptoms. Despite the warning, the prescriptions continue. Here is part of the neurological cost. Antipsychotic drugs largely function by suppressing dopamine, the neurotransmitter deeply connected to movement, motivation, reward processing, and executive function inside the brain. When dopamine remains suppressed for long periods inside an aging brain, the consequences can be devastating. Emotional expression becomes dull. Thought processing slows down. Memory storage weakens. And over time, neurodegeneration may accelerate far faster than families realize. Research published in The Lancet Healthy Longevity during 2022 followed more than 25,000 older adults. The findings were alarming. Seniors prescribed antipsychotic medications for behavioral symptoms showed a 71% greater chance of worsening cognitive decline within just 12 months, even among patients who had never previously received a dementia diagnosis. That matters enormously. If someone you love lives in a nursing home, assisted living center, or memory care facility, and medications such as quetiapine or risperidone are being used without confirmed psychosis, ask difficult questions. Demand clarity. Ask why the drug was started. Ask whether there is a strategy for discontinuation. Ask which non-drug behavioral interventions were attempted first. You deserve those answers. Now we arrive at medication number 2, paroxetine. This drug does not receive nearly enough scrutiny, and honestly, it should. Paroxetine, sold under the brand name Paxil, belongs to the SSRI family, selective serotonin reuptake inhibitors. That places it alongside medications like Prozac, Zoloft, and Lexapro. Most people hear the term SSRI and immediately think of a newer, safer generation of antidepressants compared to older psychiatric medications. For most SSRIs, that assumption is reasonable. Paroxetine is different. Unlike nearly every other SSRI on the market, Paxil carries substantial anticholinergic activity. That single pharmacological distinction changes everything. While medications such as Zoloft and Lexapro leave acetylcholine largely unaffected, paroxetine interferes with it in ways that resemble the much older tricyclic antidepressants. And that interference matters deeply for aging brains. A broad review published in Frontiers in Psychiatry during 2021 found that elderly patients taking paroxetine demonstrated measurable declines in short-term memory and verbal recall during the first year of treatment. Comparable declines were not observed among patients using other SSRIs at similar doses. The American Geriatric Society eventually added paroxetine to the Beers criteria, an official list identifying medications considered potentially inappropriate for older adults due to elevated safety concerns, specifically cognitive complications. Here is the frustrating part. Paroxetine is frequently prescribed to seniors struggling with anxiety and depression, precisely the population most vulnerable to its neurological side effects. The solution, at least conceptually, is often straightforward. If you are over 60 and currently taking Paxil, speak with your physician about whether another SSRI such as sertraline, sold as Zoloft, escitalopram, known as Lexapro, or a similar alternative could provide equivalent antidepressant support without the same anticholinergic burden. With proper tapering and medical supervision, many patients transition successfully. And now we come to the final and most important entry on this list: anticholinergic polypharmacy. Remember earlier when I mentioned that number 1 would not be a single medication? This is why. One drug alone may produce only subtle cognitive symptoms: slight forgetfulness, mild confusion, occasional brain fog, easy to dismiss, easy to blame on age. But real life does not operate through isolated medications. Most seniors are not taking one prescription. The average American over 65 uses 4 or more prescription medications every single day. Many take 6, some take 8, others exceed 10. Prescription drugs become mixed with over-the-counter remedies, sleep aids, supplements, allergy medications, and pain relievers, often prescribed by different physicians who may never fully review the complete list together. That is where the danger multiplies. When multiple medications with anticholinergic effects are combined, research suggests their impact does not merely add together. In many cases, it compounds dramatically. An analysis published in Age and Aging during 2022 tracked more than 280,000 older adults. Researchers used a validated scoring system known as the Anticholinergic Cognitive Burden Scale to measure medication exposure. The result was staggering. Patients carrying the highest anticholinergic burden showed a 120% increased risk of developing dementia over a 10-year period, more than double the normal risk. And most of those individuals had never once been warned that their prescriptions could affect memory or cognition in that way. Let me show you what this looks like in everyday life. Imagine a 70-year-old woman named Dorothy. Every evening she takes Benadryl PM to sleep. She uses oxybutynin for bladder control. Recently, amitriptyline was prescribed for nerve pain in her feet. Each morning, she also swallows an over-the-counter acid reflux medication. 3 of those 4 medications carry anticholinergic effects. Individually, every prescribing physician considers the treatment appropriate. Each drug on its own appears acceptable. But together, Dorothy's total anticholinergic burden may already fall into a range associated clinically with major dementia risk. And nobody calculated it. Not the pharmacist, not the specialist, not the primary doctor. This scenario is not fictional. This is Margaret. This is Dorothy. This is someone living down the street from you. This could be your spouse, your parent, your closest friend. The medical term is polypharmacy, specifically anticholinergic polypharmacy, and it may represent one of the most overlooked drivers of dementia-like symptoms in older adults today. Now listen carefully, because this next point matters more than anything else in this discussion. Medication-induced cognitive decline is often reversible. I have seen it happen repeatedly. When the drug burden is identified correctly and reduced methodically under medical supervision, many patients experience dramatic improvements in mental clarity. Memory begins returning. Personality traits reappear. The mental haze starts lifting. The brain is not passive tissue waiting to collapse. It adapts. It heals. It responds when given the opportunity. So here is the action plan. Start with step 1. Write down absolutely everything you take: prescription drugs, vitamins, supplements, sleep products, allergy medications, pain relievers. Include the occasional nighttime pills too, not just the medications taken daily. Step 2. Search every medication using the Anticholinergic Cognitive Burden Scale, often abbreviated ACB scale. It is publicly available online and assigns risk scores based on anticholinergic activity. Step 3. Schedule a full medication review with your primary physician. Use those exact words. Say clearly that you want to evaluate your anticholinergic burden. A competent doctor will respect that conversation, not resist it. Step 4. Ask specifically about deprescribing. This refers to the medically supervised process of reducing or discontinuing medications that are unnecessary or excessively risky. It has become an increasingly important field within geriatric medicine. Step 5. If your concerns are dismissed, seek another opinion. That does not make you difficult, it makes you responsible. And remember, geriatric pharmacists specialize in exactly this kind of medication analysis and can perform detailed reviews many families never realize are available. Now, before we finish, I want you to think carefully. How many of these medications are currently sitting inside your home? How many are being taken by someone you love? Have you noticed brain fog, confusion, personality shifts, memory gaps, difficulty concentrating? And did you ever connect those symptoms to medication use? Many people never do. That is why conversations like this matter. If this information opened your eyes today, pass it forward, share it with family, send it to friends, post it where someone else can see it. The person most at risk may never think to search for this information themselves. You may become the reason they finally understand what is happening. Protect your mind, stay alert, stay informed, and never assume cognitive decline is automatically part of growing older. Please leave your thoughts about this content in the comments below. Thanks for watching. See you in the next one.